Today we are going to talk about a very, very important and an interesting topic of diabetes. Now, normally when we talk about diabetes in children, we always talk about type 1 as the primary focus. But today what we're going to do is that we'll discuss about 6 cases who presented like type 1 diabetes, were managed with insulin at one point or the other, but ultimately they had something interesting in them. As to some of them might we are able to switch over to a particular oral medication. In some cases we were able to look at more complications, other issues. So this is the importance of how we go beyond type 1 diabetes, and this is what we're going to discuss about today. We have got 6 interesting cases which will be covered sequentially, covering the entire range of non-type 1 pediatric and adolescent picture in that regard. How do you classify diabetes? Onset less than 6 months, you think of neonatal, do imaging and then genetic studies. If the imaging is not clear, you want to know whether pancreas is formed or not. What is the better test, Naveen, in this setting? Which test will give you pancreatic information?
So we can do a stool test, or we can do
Yeah. So fecal elastase is the best marker, because even on CT sometimes pancreas is not very clearly visible. Now, if the onset is after 6 months of age, whether there is a decayed presentation, yes, and the child is needing insulin, this is type 1. Don't worry. So decay at onset, insulin requirement, don't do any workup. If you do not need insulin now, it may be honeymoon phase for some time, but maybe 1 year, 2 years, still not requirement, then you do a GAD antibody. If the antibody is positive, this is type 1. If it is negative, go for MODI. On the other hand, if there is no decay and there is no obesity, now this is a confusing picture. This can be MODI or it can be LADA, because it may evolve over time. So don't leave it, do a GAD antibody. If the antibody is positive, this is LADA. If it is negative, go for a genetic study in that perspective. And if there is obesity, no ketosis, child is stable, this is most likely a type 2 diabetes. So this is how you classify. So don't do investigations in everybody. You just classify like that. We'll take the case again. The first case, 16-year-old polyuria. What we found here was that he actually presented with DKA. But the problem was that because he was obese, we thought that this could be non-type 1 diabetes and stopped, and the problem happened that he presented with DKA later on. So if we just go by our algorithm that we have discussed, we say that this child has hyperglycemia, age is 1 to 18. He presented with DKA. He does not require insulin. You should have got a GAD antibody done, and that could have prevented you from developing this DKA. Second case, the same 18-year-old girl with increased urine output, and in this case was labeled as type 1 diabetes, even though there was no DKA, and was a lean individual. GAD was negative and turned out to be a MODI sort of a form. So if you look here, again, you have to look at in somebody who doesn't have a DKA and who is non-obese, the key parameter there is to look at GAD antibody. If it is negative, go for a MODI testing, which becomes important in that setting. 16-year-old boy with obesity, there is hyperglycemia. HbA1c is 8.3, ketone is 0.8. BMI 32, acanthosis present. What do you think here, Sain?
It's most likely type 2, sir, because acanthosis and all are present.
So this is already obesity without DKA. So again, more than 1 year, obese, no DKA. This is most likely type 2 diabetes in that setting. Now, because the HbA1c is not very high, you can start on metformin alone in this setting. And finally, you've got this 18-year-old girl with obesity, similar picture, but HbA1c is 10, mild ketosis. So what will you do here?
Sir, is the patient having osmotic symptoms?
Ketones are present.
Sir, will require insulin initially.
So better to start insulin, maybe basal insulin rather than a proper basal bolus for type 1. So this is how the algorithm will tell you. 1 to 18 years, decay is not there per se, but there is ketosis. Child is obese. You have to consider that maybe basal insulin will be required in this setting. So this is where you can classify. So essentially what you're looking at is 3 things. The age, 1 year, 1 to 18 years. Second is with regards to DKA, yes, no. Obesity, yes, no. Just 3 things, and most of the things come out from there. And then you have to do 2 things, GAD antibody and genetics.
We had an 8-year-old female whose treatment and whose all the management actually started at 2 months of age, when she had presented with poor feeding, irritability, and polyuria to an outside hospital. There she was detected with hyperglycemia, and they were told that some sort of diabetes, started on insulin, but when she came to us after 6 years, we saw that she was having fluctuating sugars. Sometimes it was hyperglycemia, sometimes it was hypoglycemia. And this is the picture which we had with us on presentation. On examination, an important part here is that the height was minus 0.11 SDS. That was fine. Weight was minus 1.29 and BMI was minus 2 SDS. So she was prepubertal, and an important fact which we saw that she had multiple bone deformities on both hands. So we got an NGS done. Unfortunately, I don't have the photographs, but the NGS clearly showed that it was a EIF2AK3 defect, which was suggestive of Walcott-Trallison syndrome. Now, why we wanted to show this case is one important thing is she has grown to a height of 115.8 minus 1, which is very rare in Walcott-Trallison. Usually they, as I will be explaining here, they do not grow up to minus 1.1 SDS. So this is basically EIF2AK3 defect. This is a protein misfolding defect, which causes insulin production problems. So it basically presents with neonatal or early onset diabetes. It's a permanent disease. It has insulin dependent. It is antibody negative, and it has tendency to have a frequent hypos as well as hyperglycemia, as we saw here. Multiple epiphyseal dysplasias in the form of, as we can see, wrist widening, and on X-ray we will see these epiphyseal dysplasias in the metaphyseal dysplasia in the wrist, platyspondyly in the spine, and these capital femoral epiphyseal dysplasias also seen, which ultimately result in short trunk dwarfism and a waddling type gait. And very importantly, most of the cases come with growth failure. They do not grow beyond minus 5 SD for the age, and beyond 10 years there's absolutely no growth seen. They might also have hepatitis. They have neutropenia. They have other issues also as well. But this girl, however, was not as sick as we had expected.
This is very unusual. So what do you think is happening?
So probably, sir, it's a mild defect or a heterozygous defect, which we...
Or maybe other genes are modifying the effect, and this is so usually when you talk about Walcott-Trallison, it is a bad diagnosis. But this girl is otherwise mentally normal, height is also okay. So this is an unusual case. That's why we discussed about this. So thanks, Pratik. And I think we discussed a lot of cases in this situation, a lot of interesting situations. So the key points are that, of course, basically think of neonatal diabetes if the onset is between 6 to 12 months. Below 6, of course, 6 to 12 GAD negative. Think MODY if lean with low insulin requirement. Liable is HbA1c in a 1-month-old. Yeah, that is a big issue. So if you have a low HbA1c, it is less reliable. But if it is high, it is significant. So the RBC turnover of neonates is high. So you may have a falsely low HbA1c. But if the HbA1c is high, it is significant. So this is the answer on that. In malnutrition associated diabetes, if they gain fat, they will develop decay. Of course, yes, this is not problem. I would say is more of environment. It is not their genetic tendency. Because they don't have fat, they don't develop decay. But of course, once they become fatty, they have a tendency of decay to develop. How lipid profile differ in type 2 MODY and LADA? So this is an interesting question. So generally in MODY, we do not see dyslipidemias in most cases. LADA, against, unless if you have a very, very high level of glucose, you will see hypertriglyceridemia in that case. Otherwise, in type 2, we tend to see more like small low density LDLs, which are there, which are more atherogenic, which are more likely in that setting. Dr. Shaila is asking, please discuss about a management in a case of nephrotic syndrome with relapse with type 1 diabetes. Is C-peptide reliable to differentiate type 1 versus steroid-induced diabetes? No, because in acute state, anything will cause low amount of C-peptide. I would go for GAD antibody. So if you're thinking of somebody who has a glucocorticoid associated diabetes, it is always better to do a GAD antibody rather than go for a C-peptide in that setting. That will give you the long-term prognosis in that regards. In any patient with transient diabetes, if it is on steroid, always think of a GAD antibody to exclude that as a possibility.